Good morning, everybody.
Good morning.
We are going to just start right off from the beginning, and we'll kind of incorporate this into everything. But say we walked right into the pre-op area. It was we were getting ready to go, identify the patient, do our thing before we come back to the operating room. And you walk in the room and their eyes are closed and they're slumped down in the chair. What do you do? Help. Exactly. You call for help first. Then where do we go? What's that?
Somebody starts CPR.
Yeah.
Okay, of course. But we haven't,
Let's
But
assess
you know,
that
you know,
patient.
Airway.
number one rule.
Sleep it.
Number one rule in that situation, right, is take your own pulse first before, right? So there's no ACLS without BLS. So start BLS, right? Start that. Get the crash cart. Sorry, but
And all that should help. So, bottom line is we start BLS. But that, in a way is really not what happens in our setting. That's what happens in the grocery store, in places like that. But in our setting, we would assess particularly first because they could be sleeping, which I've seen happen before. Really we just start BLS. But, really at this point we all just kind of fall into our roles. More than likely we'll come to the head of bed or establish airway. There'll be a lot going on around as far as, the crash cart coming in the door, CPR started, get them on the monitors, do the things we need to do with that. What do we do next? Crash cart's in the room, what do we do? We put the pads on, exactly. These are not open, so I'm not going to open them because I don't want Jayco to smack us when they come around and say you have open pads. What is proper pad placement on an adult? Where would you first want to put the pads? What is the most effective place for the pads? I'm sorry, I'm moving around. I'm good, I'm back.
Lower left.
The most effective place
Front and back.
would be front and back. Right below the scapula and right around the heart, right there. Because the transthoracic movement of the electricity would defibrillate better. I mean, in an emergency situation, it's fine to put them right there, okay? On a kid, where would you put them?
Front and back. You don't have any space.
Exactly, yeah, front and back, okay. Which reminds me, I'm going to skip to another scenario real quick and then we'll come right back. If I'm in the recovery room with a child, okay, I've just taken a 2-year-old child in who had her tonsils done and all of a sudden they spasm. What do I do? What's the first thing I do?
Get airway.
Right.
Airway is really the very first thing under that situation. I know we all scatter and go about doing, 15 different things, but under those circumstances with a pediatric patient, an airway is usually the most important thing, and that's going to fix everything else. So it'd be real important for those who are in the PACU or the CRNAs that are there to know the ambu bag's there to grab it, get it, establish positive pressure. And that's usually gonna fix a pediatric situation. But where do I go to get the cart? Where do I go to get the crash cart? RCC. That is a really important thing because a lot of times we'll drag the adult cart out of the hallway into the PACU for a kid. And yes, that is going to help you. Yes, it is okay to do that, but it would be a better idea to get the one out of RCC to bring in there.
The thing is, people that are going to get the crash cart don't know if it's an adult or a child. They're in RCC.
Well, and there's a new standard that we are going to have 2 crash carts, one in front of the red line, a pediatric and an adult, and one behind the red line, a pediatric and an adult.
Yeah.
That's a new North Carolina statute
Where are
or
we going to
something.
put that?
Besides the anesthesia machine, I'm kidding. There's also some discussion, I don't mean to veer off too much again, that the drug boxes will now go away. And everything will be pre-filled syringes in the Pyxis. Now that's just rumor, I haven't heard anything about that,
In the
but it kind of
Pyxis?
goes along.
But that doesn't mean you're going to have to go to the Pyxis.
It doesn't mean you're going to have to go to the
Oh,
Pyxis.
okay.
Yeah,
For code, no.
yeah, okay,
The drugs will be in the carts.
yeah.
Okay.
They'll be in, yeah. I mean, but they're pre-filled syringes, you pop it open.
Oh, okay.
And if you think about it, where's your
idea.
Pyxis in relation to where the crash cart is. So it'd be just as quick to go there, get a pre-filled syringe and be able to use it. So those are the two changes that, that we're looking at with that. But the one thing I wanted to establish when I asked that question is make sure if you know it's a pediatric patient, and that would be one thing that somebody at bedside could say to somebody, is grab the cart from RCC and bring RCC's cart in. Can you defibrillate a child with adult pads?
Yes.
You can. You sure can. Can you defibrillate an adult with child pads?
No.
No. Okay. What is the joules per kilogram for a child? 2 to 4. Yes.
And what's about the weight? I mean, that's kind of hard. It's
Pull out that stretch thing and say.
yeah, but according to the Zoll, it's 15 kilos.
Yes.
So 30, 35 pounds. Which
So
nobody's
they
gonna
don't
say, oh, this
weigh?
kid's about 35 pounds, but you know, so I would
Like
say,
maybe
what's that? Like
And most of the time we'll know
three-year-old
that
up.
because we've already dosed their drugs per,
Yeah.
per their weight. So we should know that, whoever the CRNA is up at the bedside. But once again, it's very important for a pediatric patient in PACU is just to establish the airway. That is the number one thing the nurse and the CRNA should go for in the beginning, and then call for the cart out of RCC. That was the point of that. Okay, so back to the first scenario. We have the adult. We've already put the pads on. What are the joules we use for an adult? 200, 300, 360. That hasn't changed. Okay. So you get the pads on. Depends on. I don't even know. Do we have paddles anymore? Do we still have paddles? We don't have paddles anymore. Good. Well, with this, it is very nice because what it will do is analyze the rhythm. But if you already know the rhythm and what's going on, of course, you want to check the pulse. This will analyze the rhythm for you, and it will tell you to shock or not shock. Okay. But through that process, remember, we got to continue CPR until until the pads get on. We continue CPR until they figure out what is going on.
That was huge. That was huge. And anybody who's taken ACLS recently, that was huge. They're just like, I know it's difficult, but they're like, try as little interruption as possible. So keep doing CPR while you're trying to get the pads on. It's not easy to do, but that was a big emphasis last time.
Yes,
with ACLS.
just continue on with everything. The beauty of this thing is it is a monitor as well as a defibrillator as well as a pacer, and we'll go over each way to do it. Do you guys want to come up and do you mind getting out of your seat, or can you see from there? Do y'all ever get to touch this? It's a good thing you don't get to touch this.
Wait a minute,
You're not putting leads on.
everybody get away from the camera.
Yeah. It's a good thing we don't have to touch this. We rarely do. Can y'all ever remember shocking anybody here or going through it? No?
Jesus, Tim.
I'm not here. I know, don't start anything. I know.
It has been used. It was out.
Right.
It
Oh,
was
yeah,
yesterday.
I remember that. Okay, so this is our new monitor. We all had that little in-service that they did with that. To monitor, this is the on and off button here. This is kind of the control button that does everything. To monitor, you just hit to monitor. Okay, and it should pop up. And you can use this transporting. We could use this to transport to the hospital if we need to. It allows this to analyze and assess things. Your pads are back here. Your EKG cable is back here, and you just put it on. I would also advise putting them on your regular monitor if you have that opportunity. This also monitors CO2. I wouldn't worry about that. There's not really a lot of situations where you need to monitor CO2 out there. But, okay, back to our scenario. So if we hook this person up, we're going to go through some rhythms in a minute, and they're in ventricular fibrillation, which is just a squiggly little line. What do? Shock them, okay? So what we would do is, you see with this, your off button, your monitor, which is where we're on, is just for assessing. You have the pacer down here in green, and we'll talk about that in a minute. But your defibrillator mode is all up here in the orange. Okay, unless I'm colorblind and that's red.
Red.
But is it red?
It's both.
Yeah.
It's got orange red.
It's sort of orange.
It's
Yeah.
orange.
It's burnt orange.
It's red.
Okay, so we're going to switch over into the defibrillator mode here. Okay, and it'll immediately go down to 120. Now what this does is, the neat thing about this particular machine is, while you're doing CPR, I'm going to kind of bounce around a little bit here. This measures the depth of your compressions and the rate of your compressions, and it will correct you. Now, whether it does it verbally, I can't remember, whether it says,
It does.
It does.
push harder.
I think it does.
Okay, yeah, I thought I remembered it did that. But it will analyze your compressions also to maximize, you know, the oxygen to the tissue. The other thing it will do, you can hit analyze here, it will
Stand clear.
It will analyze your rhythm. It will tell you what to do, whether a shock is necessary or not to shock. You know, of course, sometimes you may override what it tells you to do.
Don't try to be a hero. If you get
Yeah,
tired
don't try
doing
to be a hero.
compressions, just go on out. I mean,
Just stop.
just.
Oh yeah,
No, I
stop.
mean, just-
No, there's no reason
No,
for
no, if you
us
get
to
tired,
hurt.
if you get tired doing compressions, get ready to switch.
They
because-
recommend switching after every
Yeah.
After every
five
yeah.
cycles,
Yeah.
yeah.
Now at that point, our adrenaline's going so much.
Yeah.
Yeah.
And hopefully it's resolved by that point. That is always my desire, is a quick resolution for that. So what you would do is analyze it. If it gave you a shockable rhythm, it would tell you to clear and then shock. And we always have to make sure that we clear the bed too, and that's never an issue because everybody's yelling clear. Then you would charge it and it would deliver its shock. Here is your energy select, and that will take you wherever you want to go. Up, so there's 200. Okay, it's not letting me do too much with it right now.
That's
But-
can I interrupt, just say, that's as high as that one's gonna go.
Yeah, because of it's,
That's
the
as high as
biphasic
you
and
go,
monophasic.
it starts at 120.
yes,
And then
yes.
it's,
With
that's as
this
high as
one.
it can go,
Yeah.
is at 200.
And that's the difference in biphasic and monophasic and all.
Right.
So yes, so it will tell you what to do with that. Is that pretty? Well, let me do a couple of things here. Here's your lead. It's always a good thing to change your lead if you want to. If you're not getting what you want to see, you can hope and push that button and change it to another lead, and it'll shift leads around. That is your size buttons. That is your alarm suspend button. Your recorder, it will record. Theoretically, and I guess when this, I have to apologize and I'll find out and let y'all know. This supposedly will communicate with Epic.
I hadn't heard that.
Yeah, I remember when it
Wireless?
originally came out, and it will be a matter of having the cable that will connect into our monitor. And I will check into that and let y'all know. I apologize I didn't do that. But I remember when this first came out, they said the beautiful thing about it was it will connect to Epic. Okay? Another thing I need to find out, which will be good, is do we truly need somebody to be manually charting anymore? On Epic, it does have a code blue section that we chart into, and it does everything that, you know, we're supposed to do.
Yeah, one inch
Yeah.
on paper chart.
I
Yeah.
think probably
Well-
because of all the excitement that's going on, it would be good to have someone manually
To double,
Yes.
chart.
yeah,
Because
that's,
usually getting on the
I agree
computer
with
is
that.
something that's not happening while this is going on.
Well, because I don't know exactly where the code blue thing is in Epic.
Well, it would
Yeah.
take a little while, and we probably need to find it.
If y'all know, if you know where it's at, I'd like to show you.
Okay,
And
I'll
is
show
it
you
in
today.
the OR
It's on
also?
I doubt it's in you
Explain
guys, I
It's
bet
in
it is Epic
anesthesia.
anesthesia, ours is a little bit
Okay.
different than y'all's,
And
but
there
supposedly
probably
comes.
is one, we'll just have to make sure it's loaded in there.
Yeah. I know there is one on the anesthesia aspect, but a lot of times we don't communicate with what that, our computers don't communicate with what that is. Okay, if you shock, you get back a sinus rhythm, what do we do then?
Just keep monitoring.
Just keep monitoring, right?
Get them out of here.
How many shocks can you deliver? That's right, get them.
As many as you need to get them back.
As many as you need to get them back in the end, okay? The other thing about that aspect is just remember when you go in there, you guys are also seasoned, that you know to find your role, okay? And there should be somebody in the lead, be it, you know, Joe at the head of the table or whatever, that, you know, in theory should say chart, you know, compressions.
And then you know, it would be, I mean, people would come, the cops would come running from everywhere, so.
Yes.
You know, so you'd have an ologist at least, you know.
Yes,
so
yeah.
there'd be a bunch of.
There are generally more people than you desire. And the other aspect of that is you're more than welcome to clear the room, you know, from
Question, and
access people, yes.
I may have overlooked this in ACLS, but is there a certain age of children you can't defibrillate?
No.
Okay. Like a baby, newborn baby or
Yeah,
something?
I pray to God
Any-
that you don't.
No, I know, but I'm just,
Yeah.
you know,
But
I didn't
it's
know if
also
there was.
so rare for little kids to be in
Yes.
pieces.
Right,
Yes,
right.
yeah,
So,
it's,
but you can defibrillate them.
Yeah, especially kind of cardiac animals. And in answer to your question you asked, had we ever defibbed here? We have.
Good. I bet.
In the lobby.
Yeah,
Yeah,
So it's
we
coming,
send
yeah.
them.
Missed that one. Oops.
I had, we
Twice
had a
in the
case that
lobby.
wasted long day surgery as a patient that was in the recliner, that arrested. So you can't do chest compression.
In a recliner.
You
No.
have to ease them to the floor.
Pull 'em, yeah, yeah.
And that patient's not making it.
And
Leave
we
that
have
karma
had
over there.
someone who went out and we had to put them on, a stretcher.
Right.
And we did some chest compressions, but they came out, we didn't have to shock them.
Yeah, leave that karma over there.
I left it as a
Quick question, you actually have to push the button, right, though, it don't defibrillate
Yes.
automatically,
No,
does
it does not.
Okay.
No, not like an
It'll
AED.
take a shock, shock to
Okay.
that.
Okay, so if we come in and we find somebody with a heart rate of about 20, okay, and they want you to externally pace. The pacer part down here is in the green, and you would just turn it here, and once again, it will analyze your rhythm for you. Now, there's two things you gotta do with your milliamps, with your output, and you have to do with your rate. Anybody got any idea about what output we would use to start somebody pacing?
The
Whatever
MA,
will catch.
the MA dial.
Until they capture, that's right, and then go a little bit farther, 20 or so above. Generally, it's between 40 and 60, if I remember correctly, is where it starts to capture. But after you capture, you know, you just play with it and just kind of tweak it
When
to
they
what
start
they want.
jumping, they'll start, they jump too, it's
Yeah.
kinda weird.
It is a weird thing. People don't like that.
No,
I
it
wonder
hurts.
why.
It hurts.
And adjust the rate. And generally what they'll tell you to do is go 20 or 30 above. I mean, use your smarts about that. It's all about vital
And
signs
if you don't
and
know where to
stuff like
start,
that.
60 or 70 is fine.
Yes, 60 or 70 is fine. Because most of the time, I mean, if you're gonna be pacing somebody and they're 25, you know, if you go 30, they're gonna be 55 or whatever. Once again, transthoracic is really good. Have it on the front, have it on the back. Okay? That is what works better. Questions about any of that?
Okay, so if you got into that scenario, you got the pads on, would you also have the leads on from this machine? Or
Yes.
the leads on from your monitor and saying pre-op, say if somebody did that, break
The
it down?
answer is E, all the above.
So have all of them
I
on?
would, yes. Do you agree?
Sure.
I mean, there's no reason why not to.
Okay,
My feelings are, and this is just my opinion, is that our monitors are a little more sensitive than this guy is, you know?
Okay.
I mean, they're gonna pick up whatever it is anyway, but if there's some question because of low voltage, you know, your QRS, having a low voltage, I would just as soon have them on another monitor as a backup also.
okay,
Does
so
that
have
make
all
sense?
of that on.
But it is okay to transport with this. If we're doing pacing and we're transporting over to the ED, you know, to go to the cath lab or whatever, you know, this is your monitor and your pacer. Yes.
Now, is there another Zoll here besides that one,
Yes, and it is in RCC.
with, along with the pediatric one?
It's, for either.
Yeah,
Either or,
it will do
okay.
the same.
It has
Yeah, the
both
cart
pads.
is the only one that's
Both of them
different.
have both pads, don't they?
And
Yes.
adult pads are in the pediatric cart also,
Yes.
because if a child's over,
Which they
80
use.
pounds, then you have to go to the adult cart.
And the pediatric pads are on the adult cart?
They used to be there, we don't keep them there anymore.
Why?
Well, that and
They have a pediatric cart.
We
Yeah.
have a
the
pediatric cart.
pediatric part, which is right down the way, but, yeah.
And it's a Braslow's cart, so if you're familiar with the Braslow's tape, you don't know how much the child weighs, you can get it by length, and all your drugs are listed out. And
But
there's
they're
a
color
drawer.
coded
It's
too,
color
aren't they now?
coded.
And that is in the top drawer of that cart. So when you pull that out, you know, you can take that pad. I mean, most of the time, things have already happened. By the time that gets out, we figure out that, you know, the length and all that, we've already generally got them back.
Maybe we need to look at that card, because I'm not familiar with that.
No, I didn't know we had
That
one
part
until
of
we
it.
had that little baby. You walk by it every morning. Yeah.
Well, you don't
I know, you don't
Open it,
realize.
you know, without-
Yeah.
Yeah,
I was
don't
going to
open
get
that
the
part,
adult
'cause
and
it's a
somebody
lot
else
of
went
money
in.
Lock
to,
it.
to put that little plastic tab on it. If I remember right, it used to be about $500 to put that little plastic tab back on.
Well, the bad thing is, if we're in a room and, okay, so a kid goes down, you press the blue button, but whoever's outside grabbing the cart doesn't know that it's a kid
I
necessarily.
didn't know that we're supposed to grab the cart from RCC for a child. This is the first I've heard of it.
Well,
There
I
you
have
go.
heard that, but again, if somebody just yells out, go grab the crash cart,
You
you're
get-
gonna
You're
you
go,
gonna get the
automatically
crash
assume
cart
they
in the
get the
hall.
cart.
right, that's the hard thing.
If it's a kid
Yeah.
and I'm in there, you'll probably hear my voice all the way down the hallway,
But
you know?
the issue with that too is that, like he said, most of it's airway and they can fix that anyway. And if not, they've got so many drugs already on their cart to get the heart rate up.
That's why atropine sits on top with a needle on it that will penetrate into the skin and not a blunt needle. That's why we prepare for the worst, you know, and that's what all that is for. So hopefully, yeah, it's all corrected, but yeah, I mean, that is a valid point, and yeah, hopefully whoever's circulating or whatever, because I'll tell you right then, my attention, if it's not already there, will be on that airway. But whoever's circulating can just pop their head out the door and say, we need kids.
The pediatric.
Yeah. But once again, the adult pads will work on the kid.
And does everyone know about the overhead page where if you hit the emergency, it will page everywhere, the emergency page? Some people didn't know about that either.
Oh, I didn't know
I
that.
didn't know that
Yeah.
either.
It's
Well,
listed on that emergency page
The code blue
on your
button.
phone.
No, on the
No, it's
phone,
on the phone.
there's an emergency page, and when you hit that button, the page overhead, it pages in the lobby and everywhere.
It's on our phone.
Uh-huh.
So is that just in the OR?
I don't know, what's up.
That's a little scary.
That is a little scary.
I
I don't
would
know
hate to
if
be a
that's a good
parent
thing.
out there and.
We used to have them, I remember a long
'Cause
time
they
ago,
know
we
what
had a
room the
different number,
kid's
it was
in.
5-7
By
or
that-
something.
Yeah, with
yeah.
the tracking.
But if you can't find the anesthesiologist in a hurry, that emergency page will page them wherever they are. Because sometimes they're not.
Answering
Does it
the
go
phone.
into the dictating room?
It
Exactly,
goes
'cause you
everywhere.
can't hear it.
Because the other page doesn't go into the dictating room. Unless they've got the famous term.
Goes
Any other questions regarding the machine?
Thank you.
Thank you.
Okay, let's go over rhythms real quick. I'll put them on you and then we get out of here. If we all gotta go.
Everybody got the strips ordered?
Everybody, yeah, everybody have one? All right, number one, what is that? Famous rhythm with a bundle branch block, it looks like to me. Do we shock or not shock?
No.
Number two, what's that?
That's great.
With a bundle branch block, or either somebody just got a big old hand.
Somebody just can't draw.
Shock or no shock?
No.
Okay. What if you feel a pulse? I mean, what if you don't feel a pulse? What if there's no pulse with any of these rhythms? Do we shock or not shock? You do CPR, you do not shock. Okay. What is three? Oh, let me forgive me. If we back up to two, what could we do? Pacer, exactly.
Atropine.
Okay. And with the pacer, yeah, actually atropine
Yeah,
is
you
great.
do
That's what, you know,
Yeah, you do atropine.
hopefully by the time that, you know, the monitor came, the defibrillator, that would be resolved and their heart rate would be 160 because
Yeah.
we've overcorrected.
Yours would be 200.
And when they get the pads in, we put the pads on, pads go where? Front, back, transthoracic. We turn the voltage up to where we capture, and then we start playing with it there. We turn the rate up to, like Joe said, most of the time 70 is a good place. Three, what is that? What do we do with that? CPR, do we shock it? No. What about four? Atrial flutter, the beautiful sawtooth. Do we shock it? Not normally, no. Most people tolerate that quite well, and if you see the rhythm is not that high. It can be shocked if it, you know, in due time, but most of the time they treat that with drugs.
I'm gonna throw a personal thing in there. Just some, because we, you know, have ICU backgrounds. Sometimes I think we can tend to get too caught up in the rhythm, so look at that, you know, what we're supposed to do. But you have to look at the rhythm, but also I was kind of taught the Braille method, you know, rhythm, pulse, what does a patient look like, right? So is this a rhythm that they can tolerate? Can they tolerate it, or does it need to be terminated? That's the bottom line. Do we need to go to something else? Does it need to be sped up? But that's what I was always taught, you know, look at, how's the patient doing? If I look at that and the patient, they look like they're getting ready to go out, it's okay, but they're talking to me, then you know what, I can probably deal with this, you know, so like I said, I think sometimes we kind of get, you need to know major rhythms, but since we're not, you know, we're not EKG specialists here, Look at the, yeah, when the bottom line is you look at the patient, sometimes they tell you, you know,
What you've always heard, you treat the patient, not
yeah,
the.
not the monitor, right.
Well, a lot of patients live in AFib and flutter.
They do.
Exactly.
They do.
A lot of
And
them.
some people live in, some
We see
people
them
live in
all.
slow,
Yeah.
and some people, and some people live in slow atrial
Yeah.
fib, you
Yeah.
know, so, anyway.
And that being said, too, I was called one time to CCU for a cardioversion, and it was a young African-American gentleman who's in his 30s, who's sitting bolt upright in the bed and was in a VTAC of about a rate of 110.
Yeah, and I've seen, yeah, people.
Well, my dad does.
It's on a VTAC.
And he just compensated, that it was just a sustained compensated VTAC that carried on. And we wound up defibrillating him and getting him out of it, but that's a whole nother story in itself. What is 5?
With a button.
With on the branch block? Shock or no shock?
They may try cardioversion.
Depends on the patient, yes, depends on the patient. What about 6? Shock or no shock?
Yes.
Okay, where are your pads? Front and back? Okay. And once again, do they have a pulse to, you know, all that? Yeah, most of the time you walk in with that, you're gonna get shocked. How about 7? Shock or no shock?
Yes.
Absolutely, yeah, absolutely. All right, questions about anything?
Did you wanna do any of the sync?
Oh.
The sync stuff?
Good idea, why don't you do that? Show me where the sink is.
Everyone, if you wanna come up here, if y'all seen it with the sync button on here, if you're doing a, you know what I'm talking about? Okay, where you're doing somebody's in like atrial fib when they're not tolerating it, okay, so the main, you set it to defib, okay, and then of course your joules are gonna be a lot less, anywhere from 50, right, I'm just trying to get it. So, and the main thing I find with these when you charge, okay, is you have to program your mind to like hold the button until it hits the R wave so you can sync. And that's like, cause we just wanna hit it and get off, but you have to stay on it until it can recognize the rhythm and then shock, that's always a difficult thing for me to do, to remember to kinda hang on, so.
So this one, you have to reset it though too, every time, don't you? Like if you sync them once and you shock them, don't you have to come back and re-sync it?
Yeah.
Or some of them,
Right. But
And
that's
you
all.
know it's sinking because there's a little
You'll see,
green
yeah,
light
you'll see spikes.
on the
You'll see
R wave,
spikes, yeah.
on the up wave.
You guys have to sign these, or we just put the name on?
I don't know. I'll let Monica.
Yeah, Monica's got it.
Everyone keeps their own, and if Sandy needs it for your evaluation.
Yeah, I think that's where you
just have her
guys,
sign it, she-
I think
It
that's saying that
says
you
an
went through.
evaluator needs to sign it.
Oh, do we?
I'll have to sign them.
I'll say just sign my name.
But part of it's too, we
My
try to
name's
make
Jeff
this not
Conrad.
just a Zoll, like a Zoll review, but just kind of a, you know, God forbid, you know, we don't do, it's not like the main where you're doing a code every, month or so, hopefully, so, or every couple of weeks. So it's just kind of everybody, hey, something happens, it's easy to get lackadaisical, so if something happens, what do we do? So,
I really think we need to do like a mock code situation here, like
Yeah.
at least once a year.
I was just thinking too, you said about it,
We had a bunch.
I know it's $500, but you don't know what's in the cart until you bust open the cart and see what's
We
in
have
it.
to call pharmacy and ask them.
Yeah,
They'll let you
and I wonder if we could do that, just kind of get in there and bust it open and just take a look and see what's,
everything-
We have
Yeah.
2 old carts right here now,
okay.
so that I
I
can
think-
call and see if we can bust those
I
open.
think that'd be a good idea,
Play with 'em.
just,
I think that's a great idea, because you
Because-
really don't know what's.
and you don't have familiar, in the middle of a code is not the time to try to become familiar with stuff.
Where's that?
Yeah, what's that?
And you know, looking, where's that?
It used to be, you just, the thing, put another one on it.
Can't do that anymore.
Replace what you use.
And the nice thing is most of the time, we'll be armed with stuff. I mean, we'll be armed with the Nectine, we'll be armed with, atropine and stuff like that, so
You
a
guys
lot
have
of the
by carb
necessary
also on
things,
your
but
cart?
It is so rare you ever use bicarb anymore in any kind of
If you do, it's
codes
way
or
on down.
anything.
It's way on down.
It is way, I think it's even off the list now.
And epinephrine's the number one drug.
Yeah,
that they
Epi's
got.
the thing that we'll always need.
For the
And
Tourette,
just in case, just so you guys will know this, it is always Epi's in the second drawer of our cart on the right-hand corner. Just in case we're like in the
Crash
hall.
cart.
No, our
In the anesthesia drawer.
anesthesia
I'm sorry,
cart.
can you repeat that?
It's in the second drawer. You'll open it up and you'll see where all our drugs are. It's in a box on the right-hand
Yeah,
corner.
the med drawer.
So if we're ever in the hallway and we're getting ready to turn around and something happens, you know, and we say, grab some Epi, that's where it is. Second drawer on the right side for us.
And your Epi's 1 to 1,000.
Yeah, it is pre-mixed in the thing, so yes.
Oh,
that
Sorry.
would be the adult cart.
Thank y'all very much.
Thank you.
Good job, Tim. I just stood here and said, good work.
No, 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 no.
I forged their name.